Hey guys, can you guys see me, hear me? Okay. Hey guys, welcome back. So am I audible and visible? I hope I am. If so, tell me a hi and hello. Hello Jane Medico, good evening. Okay, I hope I'm audible. Good evening, Ankita. Okay, great. So I have skipped apoptosis because the naming and other things are not yet clear. I think once the puja holidays are over, I'll talk to the team and make sure the naming becomes normal. So I'm starting protein and fat accumulation, which comes under intracellular accumulation in Robbins. Apoptosis, I'll definitely take care. Definitely once we complete intracellular accumulation of protein, fat, calcium, then we'll definitely talk about apoptosis. Fine. Chef here, I'm an MD pathologist. Okay, so let's start. So we are going to talk about protein and fat accumulation, right? So this is a type of an intracellular accumulation. We can have proteins, fats, pigments, calcium, anything can accumulate inside the cell. First thing, what is this intracellular accumulation is? I'm just going to ask you a very simple question. We have read about necrosis, right? So tell me, let's assume you have a fever, or let's take acute pancreatitis, right? Because we have read about acute pancreatitis in detail, right? So will the patient come to the doctor immediately during acute pancreatitis, or the patient will take some time? And if the patient comes to the doctor, will the biopsy be taken immediately or it will take some time? Even when you have fever, we don't go to the doctor on the first day, right? We take 2 or 3 days and then only we go to the doctor, right? So what happens is, for any disease for that matter, even if it's an acute disease, the patient comes to the doctor a little bit late and the investigation also done a little bit late, right? Which means I will not always see necrosis in the microscopy because it has happened 3 days back. Now necrosis will not be there, right? So I will always look at the evidences of cell death. All the intracellular accumulation are evidences of cell injury, right? So we did read about saponification yesterday, right? Which type of necrosis we read about saponification? Anyone? I'm sure you must have remembered that. Saponification we read in fat necrosis, right? So I'm going to ask you a question. Is there a possibility if I look at an omental calcification or an omental saponification, can I say this patient must have had fat necrosis of omentum long back or acute or chronic pancreatitis long back? Yes. So when I look at a calcification, I can backdate and say, okay, this patient must have had a cell injury or a cell death, right? So all these are some way evidences of cell injury or cell death because no patient will come the same day of the fever and I won't take a biopsy or anything on the same day of the disease, right? That's why this happens, fine. So with that premise, let's go for protein and fat accumulation. The first thing I'm going to talk about fat accumulation. If you look at Robbins divides fat accumulation into triglycerides and cholesterol esters. Both are ideally fat. The only thing is where it's getting deposited makes a little bit of change, right? So triglyceride accumulation, we call them steatosis. Okay, it's just steatosis, which is accumulation of fat, right? Good evening, Prithvi. Good evening, Siddhartha. So here, can anyone tell me which organ is predominantly will have fat accumulation? Obviously, it's going to be fatty liver, right? Fatty liver is a very common finding. I can say that pretty much 10, maybe 5 out of 10 youngsters will definitely have fatty liver. Not because they are alcoholic, because they consume lots of junk food. That's how it is, right? Fatty liver by default is a very, very common source, right? Common place where fat accumulation can happen. And in fatty liver, the fat accumulated is triglycerides and not cholesterol. And triglycerides is what will get accumulated in the fatty liver, right? Now, let's kind of understand what happens behind fatty liver. Though we'll read fatty liver under liver pathology, just a premise of it, right? Now let's take liver as an organ. Am I right in saying that the function of liver is metabolism of fat? One of the functions? Definitely. Liver definitely metabolizes fat. That's one of the functions of fat, of liver, right? Along with detoxification, right? Now, if a person is going to consume excess amount of fat consumption, can I say liver will not be able to metabolize it normally? Because liver has a ceiling limit, right? Beyond a certain limit, I cannot obviously take care of it, right? This is what I said, all the junk foods. We call them NAFLD, non-alcoholic fatty liver disease, which most of us might have, right? I am pretty much sure I will have a grade 1 fatty liver, right? Because of the abundant consumption of food, more than what my body can tolerate and more than what my liver can tolerate. It's non-alcoholic fatty liver disease, right? At the same time, we also have alcohol as a cause. we will see why alcohol actually will cause fatty liver, right? Have you read about alcohol metabolism in your first year biochemistry? Have you come across the term alcohol dehydrogenase, aldehyde dehydrogenase, alcohol becoming acetaldehyde, methanol becoming formaldehyde? You must have definitely read about that, right? So when I have an enzyme called as dehydrogenase, what do you think is the cofactor? What comes to your mind? Can I say NADP, NADPH? That's a cofactor for dehydrogenase. Dehydrogenase means removes the hydrogen, so it goes from NADP to NADPH or FAD to FADPH, right? That's how most of the dehydrogenase function, right? So when alcohol is metabolized, so what happens is this will result in excess amount of NADPH because the dehydrogenase functions and the hydrogen will go here, right? So again, if you remember biochemistry, can I also say NADPH is very much involved in fatty acid oxidation and the the creation of fatty acids? It is the fatty acid synthesis, the cholesterol metabolism. Everywhere your NADPH is very, very important, right? So this excess NADPH will result in increased production of fat. That kind of deposits in the liver. That's how alcohol causes fatty liver, because of more and more and more synthesis and less and less and less beta oxidation, more and more fat accumulates. That's how alcohol does it, right? Next one, PEM. We did read PEM when we read about atrophy, right? Protein energy malnutrition, Kwashiorkor marasmus. What will happen to the peripheral fat and peripheral muscle? Will it be wasted? It will be. So all the peripheral fat will be dissolved and destroyed, will automatically go into the liver, right? In PEM, there will be increased peripheral conversion and they will obviously go into the liver, and the liver will not be able to metabolize it normal. So obviously it ends up in having a fatty liver, right? That's how your PEM can also cause fatty liver. At the same time, there are multiple areas where drugs, okay? Drug induced fatty liver is also a pretty common thing, because what predominant of the drugs do is drugs kind of affect or destroy your mitochondria. That's how predominant of the drug works. We'll read in detail when you come to liver pathology, like I said. Am I right in saying that beta oxidation happens in mitochondria? Again, going back to your biochemistry, biochemistry plays a major role in understanding and processing things, right? Beta oxidation, mitochondria is one of the important things. So when mitochondria is not functioning properly, obviously the fat metabolism will not be proper, and more and more and more fat accumulates, right? So these are few causes. We'll definitely read more when we come to liver pathology, right? These are few causes which causes fatty liver. Now we know that fat is getting accumulated in the liver. We are going to read about the gross and the microscopy. Microscopy is more important for us. Gross is also to some extent important, right? So now, if we have a gross appearance, gross is with naked eye, right? I'm going to ask you very simple questions. I want everyone online to answer this. What will happen to the size of the liver? Bigger, smaller? It will be bigger because something is accumulating here. So we use the term hepatomegaly, right? So you'll have hepatomegaly where you'll have excess accumulation of fat, which is increasing the size of the liver. That's the first, right? Second, what do you think is the gross color of fat? What do you think is the gross color? How does fat look in a naked eye? Everyone knows that. You've seen ghee, right? You must have seen butter, cheese, chicken fat, anything, any fat. What's the color? Oil, yellowish in color, right? So it'll be hepatomegaly. It'll be yellowish in color, and obviously it'll be greasy. The greasy thing can be felt only when you touch it, right? Fat will be yellow for sure. Pitbull dog is king. Brown color will happen once I'm converting them to trans fat, once it's been burnt. That's what the brown color. Normal fat color is yellow, right? So I'll have yellowish and the greasy feeling will be there if I am able to touch it, right? That's gross. Now let's look at the microscopic, right? So I have told you a thumb rule to remember things in H&E. How many of you remember that? If you remember, can anyone tell me what is the color of fat in a microscopy or a biopsy? Microscopy color of fat, biopsy color of fat. Pink, blue, or clear? What do you think is the color? Clear, perfect, right? Now our goal is to understand why it is clear, white is the background color, why it's clear, right? Because fat has an yellow color in naked eye. So microscopy, they should have some color, right? This will definitely come in a viva. Do listen to this carefully, right? So whenever you take a biopsy, so I have something called as processing. We process the tissue, okay? Processing involves multiple stages of alcohol. If you get time, please go to your pathology lab, histopathology lab, and see how a processing is done. It's done for over 17 hours. We process the tissue slowly and gradually, right? This processing will dissolve fat. So it dissolves fat and it kind of removes the fat. So once it dissolves fat, what I am seeing in microscopy is empty space or fat. I am taking a biopsy, I cut them into thin slices, process the tissue, and then I stain. This processing will dissolve or remove the fat. So what I'm seeing in microscopy is actually not the fat, it's actually the empty space. It's completely empty. Empty space where the fat was present. Because the fat is removed by dissolving, I won't be able to see any fat at all here, right? That's why fat appears clear. It's actually not the fat, it's a clear space. So obviously anything empty will look in clear, right? Now I am going to tell you one more thing which I want you to remember till we learn pathology and medicine. So now in microscopy, my fat is clear. Okay, I'm going to ask you two questions sequentially. We did read about hydropic degeneration or water excess or cell swelling, right? Can I say water also will be clear in microscopy? Is that statement right? Pretty much, right? Water also will be clear in microscopy because it's water, right? So let's assume I'm a very young pathologist. I look into the microscopy. I see a clear space. I have differential diagnosis. It can either be fat or it can either be water. With no background history, will I be able to say this is clear fat and clear water? Can I differentiate that? Yes or no? Can I differentiate that? Me or you or anyone in the world, it's clear. Can I differentiate it's fat or water? I can, right? Since fat is clear, water is clear, mucus is clear, there are many things which are clear in the microscopy. So here I will struggle. In a normal H&E, it's difficult, right? It's very, very difficult for anyone to differentiate fat versus water. Okay, fat versus, I'm just giving an example of water. It could be water, it could be mucin, anything, right? So whenever you have this difficulty, I want you to remember, I need special stain. Only when there's a difficulty, I require special stain for diagnosis. Otherwise, I won't require special stain. We will read about special stain, multiple special stains. But the first question is, if I cannot differentiate this from another thing on a H&E, I require a special stain, right? And the special stain done for fat, there are two stains here. One is called as an oil red O, okay? It's oil red O. The other one is Sudan black. Special stains are actually very, very simple and easy. It will actually tell you what color it becomes. So what will be the color of fat in oil red O? Red color. Sudan black, black color, right? So when I use oil red O, the fat becomes reddish in color. When I use Sudan black, the fat becomes black in color, right? So that's how the special stains work. It's a very simple way to remember oil red O and Sudan black, right? I'm going to show you two images. I want you to tell what stain it is and what's the diagnosis, fine? This is a liver biopsy. Can I say this is fat accumulation, right? All these clear areas are nothing but fat accumulation. You must have seen liver in histology. What's the normal color of hepatocyte? The normal color of hepatocyte, pink or blue. You must have seen liver, right, in histology. The normal hepatocyte is completely pink. That's how normally it looks, because hepatocyte has lots of proteins in the cytoplasm. They are pink in color, right? This is how a fatty liver looks like. Okay. So now, if I do a stain here, the entire fat areas is becoming different color. Can anyone tell me what stain is this? It's not difficult to identify, right? All the empty spaces in that image is become red color here. So this is how an oil red O looks. So I have a big issue here. I have a big concern. Let's see if we can discuss and sort that out. Okay. Listen carefully. I'll ask questions one by one step. I want you to answer. What stain is this? This stain, what stain is this? This is H&E, right? And in eosin and hematoxylin, fat is empty, fat is clear, right? Why is fat clear? Because fat is washed away during processing, right? So now tell me, actually in this empty space, or actually in this clear areas, clear vacuoles, do we have fat or no fat? do we have fat or there's no fat? There is no fat. Okay. So let's assume, are we on the same area? There's no fat, right? If you are the same thing, now let's go and extrapolate. If I don't have fat here, and if I do oil redo in this slide, will it become like this or not? Because there's no fat, right? Remember that. There's no fat. Will it become like this or it will not become like this? We started with an empty space. Will oil redo stain the fat in empty space? It won't. Perfect, right? Okay. Now, the reason for that becoming empty was processing, right? So now tell me, if oil redo has to work, do I need a processed tissue or not a processed tissue? What do you think is required? I have got a red color stain here. If it needs to work, the tissue should be processed or should not be processed? What's your take? Should not be processed, right? Perfect, right? So in other words, for the special stain to work, the tissue should not be processed. Okay? In other words, I need a type of section. We'll talk about that. Obviously, Anuj, they'll start from basics. You are in first year, right? Paran batch is for first year MBBS. They'll start from basics by default. Fine. Okay. Now, I am going to ask you one more simple question. If you have to preserve a food particle, right? Something food, you made a roti and dal. You have to preserve the food. What will you do? I have to eat it tomorrow. What will you do? Can I say you'll keep in the fridge? Or in other words, can I say if I freeze something, it'll be preserved? That part. So now, can I freeze the tissue also to be preserved? Generally, when I use liquids for processing, fat is dissolved. So here what we do is, I freeze the tissue, we call it a frozen section. When I freeze the tissue, will fat disappear or it will not disappear? It's ghee, right? Ghee is fat. When you freeze ghee, will it disappear or it will become solidified? It will become solidified. It won't dissolve away. Only when I use alcohol for dissolving or processing the tissue, it will wash away. Frozen section will not remove fat, and I can see these fat stains only on a frozen section, right? This can come in a viva. To demonstrate fat in a microscopy, I need frozen section. This will definitely come in a viva. Fine. Okay. So we know about the fat accumulation, the triglyceride part, right? Perfect. Now let's go to the second part, which is cholesterol part. Okay. Microscopy will look the same. It's more or less same clear appearance only, but the place where it gets deposited will differ. I am 100% sure you must have heard at least one or two examples of this cholesterol accumulation. You must have heard about atherosclerosis, right? Definitely, right? So cholesterol accumulation, there are few examples. One is obviously atherosclerosis. So where I have cholesterol and cholesterol esters, which are nothing but chemically changed cholesterol, right? So where you will have cholesterol, I'll write cholesterol and CE for cholesterol esters. Okay, so this will be accumulated in the tunica intima of the vessel wall, right? That's where you will get accumulated, which results in atherosclerosis, or the entire vessel becomes smaller. Fine. Okay, I'll ask you one more question related to biochemistry, right? Sorry for taking biochemistry so much deep, but that's very important for us to understand a few things so that we not memorize. That's all. Have you heard and read about familial hypercholesterolemias, hypertriglyceridemias in biochem? There'll be a huge table, multiple inheritance, LDL receptor mutation. You must have heard. You must have read. Okay. If you have read it, there is a lesion which happens in these hypercholesterolemias close to the eyelid, close to the tendons. What is that? However, it's very easy to read for more than 15 minutes if you like the subject, right? So first develop liking towards the subject, you can definitely read it, right? Initially 1 month will be difficult, after that it becomes easy. It starts with X, that's a clue. Have you heard about a condition called as, you must have heard for sure, you must have forgotten, what is xanthoma? Have you heard about something called as xanthoma? Xanthomas, xanthelismas? No? If not, let's remember it now, right? Xanthomas, perfect. Great, Meenakshi. Join MBBS and let's read more, right? So xanthomas are nothing but subcutaneous deposits of cholesterol. Subcutaneous or little bit over the tendon. They're deposits of cholesterol and its esters. I'm writing C for cholesterol esters, and these are seen in familial hypercholesterolemias, right? So it's nothing but extra deposits, that's all. Okay, fine. Familial hypercholesterolemias will cause this. Can I also say, I'm just trying to make things easier for you. If a patient has an acquired hypercholesterolemia, very high hypercholesterolemia, can this happen or it will not happen? Xanthomas are excess cholesterol deposit, right? Can it happen in acquired conditions also or only familial? It can also happen in acquired conditions also, right? So in acquired conditions also, whenever fat is more, it deposits, right? Perfect. Okay. Tomorrow is Sunday. If you have free time, I want you to go to a park where most of the elderly people will walk around, right? You must have had park close to your home where most of the diabetic, hypertensive aunties and uncles will walk. Basically, they don't walk. They'll bitch about the kids. That's all they do, right? So go and sit there in the park, watch them carefully, watch each one of them. At least for one person near the eyelid, you will have seen xanthomas. It's very, very, very common. To diagnose things, you need to observe. That's more than enough. Please don't comment ever in your life. India does not have patients and Indian medical colleges does not have patients. We have 1.4 billion people. If Harrison calls it rare, it's common in India. That's how it is, right? So observe. Just go and sit there. You will observe many, many things. Some things you will diagnose, something you don't diagnose. We don't diagnose because we don't know about it. That's all, right? Just observe. Every uncle and auntie, at least 50, 60 of them, if you observe close to the eyelids, there'll be yellowish raised lesions. That's xanthoma. That's how you pick up diagnosis. So if you observe, let's talk back by Monday. Let's see if at least one of the xanthomas if you identified, right? Then I have a condition called cholesterolosis. Cholesterolosis. It's cholesterol getting deposited. That's all. Fine. Okay. Cholesterolosis is a type of gallbladder problem. It's where cholesterol-laden macrophages or fat-laden macrophages is depositing in the gallbladder, right? It's a type of cholecystitis. Cholecystitis is inflammation of the gallbladder where you'll have fat or cholesterol laden. Laden means it's filled with, right? Cholesterol laden macrophages will be seen in the lamina propria of the gallbladder. Fine. Okay. That's also one of the conditions where cholesterol can accumulate. That's an example of cholesterol accumulation, right? Then there are few other findings. Have you heard about a disease called as a Niemann-Pick disease? You must have, right? Niemann-Pick disease, you must have read about it, right? Where you have a defect in the macrophage problems. It's one of the storage disorders where you have Niemann-Pick, you will have an abnormal trafficking, so there'll be increased cholesterols in macrophages, fine. So all these are pathological examples where cholesterol can accumulate, right? Now this is more than enough for you to write for a 5 mark. Now let's go and see how to pick up the image from Robbins. I think I have the image which is there in Robbins. It's the image in Robbins, right? Tell me this part. What is this part? I'm just trying to help you to read the images. Can I call this part as epithelium? If I draw kind of like this, can I call it an epithelium? Yes, no, maybe. I'll erase this for a convenience. That's an epithelium. Perfect, right? Let's assume this is a biopsy from gallbladder. Okay, that will be given in the question, or you'll have a history of cholecystitis, right? No one is going to give you a random image and ask you what it is. Either history will have some symptoms of gallbladder or the diagnosis will be gallbladder cholecystectomy done. Fine. What is the lining below the epithelium in gallbladder called as? This you have to know. Because in first year you must have read that, right? Layers of mucosa, layers in your GIT. Epithelium, lamina propria, submucosa, muscularis, serosa, right? So the layer below my epithelium is called as an lamina propria, right? So this entire structure here for me is lamina propria, okay? So in this lamina propria, what's a predominant color seen? Clear, white or pink? In this lamina propria, what's a predominant color seen? White, clear or pink? It's clear, right? So this entire lamina propria is filled with clear filled macrophages, right? There's an example of cholesterolosis, right? It's slightly clear. I won't call it exactly pink Jane Medico. Maybe a slight shade of pink. I would say this to be pink. Compared to that, it's definitely light pink or clear, right? It's always a gradient, fine. Okay. So I have lots of macrophages with fat laden to it, fine. Perfect. That's how cholesterolosis looks in a microscope, fine. That's about fat and cholesterol accumulation, right? Let's go to protein accumulation. Okay. Can anyone tell me what's the color of protein in a microscopy? Protein color. We already know this. Protein is always pink in color, right? So my normal protein is pink in color. So I have multiple areas in my body where I can have normal protein in excess. Also, I can have pathological deposit of protein. Both can happen in case of your protein accumulation. Could be normal or excess of normal, right? First, let's look at kidney. Okay, if you remember kidney, there's an organ called as PCT. What's the function of this organ? Resorption, right? Can I say PCT in addition to glucose and lots of ions, it will reabsorb protein as well? It will, right? PCT will have something called as reabsorption droplets of proteins. Okay, it will happen by default. It will definitely have reabsorption droplets of proteins because the function of PCT is to reabsorb all the protein. That's one, right? Second, we have a cell called as a plasma cell. This also is kind of normal or sometimes in excess, right? What is the function of plasma cell? Anyone? Anyone? Whatever comes to your mind. What's the function of plasma cell? Plasma cell's function is perfect to produce antibodies, right? Plasma cells produce antibodies. Can I say antibody is nothing but a protein? Is that statement right? It's obviously right, right? So plasma cells, again, normal function is antibody production. And antibodies are nothing but proteins. That's all. They are also proteins, right? So in cases where there's an excess of plasma cell, okay, maybe a very severe infection or a neoplasm of a plasma cell, whatever it is, right? Extreme severe infection, with excess of plasma cell proliferation, I can see the protein deposited inside the plasma cell and we give the term Russell bodies. Okay, there's nothing but excess antibody production in the cytoplasm of plasma cell, which is looking like an inclusion. We call it a Russell body. It's immunoglobulin, it's a protein, right? Perfect. The only thing what the bigger issue with medicine is not medicine per se, it's the human beings. They should have easily called it antibodies and protein deposit, right? But Russell came here and put his name there, right? Thank you, Shizad. In future, if you discover something, please stick it to basic science. If you feel your juniors want to have a nice time in enjoying medicine, if not, give your name, right? This naming is a problem. If you are told protein production, more than enough. Very, very easy for anyone to remember because pink in color, it's accumulated and antibodies will have that. That's all, right? Next. Third, I have a disease called an alpha-1 antitrypsin deficiency. Okay. This is a disease where I have a deficiency of alpha-1 antitrypsin, right? Alpha-1 antitrypsin, because of the deficiency, what happens is there are many proteins which are not folded properly, will be accumulated inside, right? Because alpha-1 antitrypsin helps in elimination of many proteins, right? In this deficiency, what happens is the misfolded proteins will accumulate. The misfolded proteins accumulate inside hepatocytes. That's one of the common places because hepatocyte does all the removal of all the unwanted things. Misfolded protein also hepatocyte will try to remove, but it will not be able to remove beyond a certain limit, right? It accumulates inside hepatocytes. Okay. So this also has the same color. In microscopy, I will see them as in pink globules. Okay. I'll see pink globules in microscopy in case of an alpha-1 antitrypsin, right? Let's slightly move away a little bit and understand one more thing in the same premise of protein accumulation, right? Now, we just now saw microscopy of a normal liver. What's the color? What's the microscopic color of a normal liver? Pink or blue? Cytoplasm was pink, right? What's the protein's color? Again pink, right? Normal liver is also pink in color, right? And can I say you must have read about a condition called as von Georg's disease? Can anyone tell me where did we read von Georg's disease? Where have you read von Georg's disease? Von Georg's, Kirky or Georg's, however you say it. Glycogen storage disorder. Can I say in von Georg's disease, excess glycogen will be stored in the liver parenchyma, right? Okay. Let's take a patient with an von Georg's disease. Fine. So in von Georg's disease, what happens is excess amount of glycogen will be stored in the hepatocytes. Fine. So this excess glycogen also has a slight color of pale pink to clear. Right, let's assume pale pink. If it's clear, I don't have a problem in differential diagnosis at all. It's easy, right? If it's pale pink in color, sometimes it will be clear also. I'm ignoring the clear part because clear part is not a differential diagnosis at all, right? Now, let's assume we got a liver biopsy. Let's look at a practical problem. Okay, a liver biopsy came to me. I'm struggling to differentiate whether it is an alpha 1 AT for antitrypsin, I'm just writing in short form, or an von Georg's disease. In other words, I'm trying to differentiate it from a protein versus glycogen, right? In light microscopy, what will be the color? Pink, right? Listen carefully and answer. If I'm not able to differentiate something on a light microscopy where both of them look pink in color, what's the next step? Everyone online answer this. I'm not able to identify on a light microscopy. What's my next step? My next step is, thank you Ayush, special stain. That's all right. So what we do is, I'm going to do a special stain. Because I'm not able to identify on a light microscopy, obviously I do a special stain. And the special stain, what we try first here is PAS. Okay, we'll keep on reading PAS more and more. PAS stands for periodic. Actually, it's not periodic. It's periodic acid shift. It's a chemical name, right? It's periodic acid shift. That's the full form for PAS, right? So when we did PAS, what happens is protein will become magenta color. That's the color of PAS. Or if guys don't know what is magenta, let's keep it dark pink, right? Let's keep it dark pink. That's the color of PAS normally. Glycogen also becomes magenta color. Can I differentiate or not? Both becomes magenta color. Can I differentiate or not? No, I'm still in the same problem, right? I started with the same problem. I did a special stain that also came with the same problem, right? So what do I do now is I have a modification here, right? That modification is I add an enzyme called as diastase. Okay, we add an enzyme called as diastase. Fine, there's a modification done for PAS, right? Diastase is a saccharidase. It's an enzyme which is present in the saliva which helps in digestion of saccharides, which is sugar. If I add diastase, tell me which will be digested, glycogen or protein? Which will be digested? Obviously glycogen, right? Once you add diastase, this will digest glycogen. Okay, protein will be unaltered because protein will not be taken care of by my sugar dissolving enzyme, right? It will digest glycogen, right? After that, what we do is we repeat PAS. Once we repeat PAS, tell me who will be positive now? Who will become magenta? Protein or glycogen? Remember, diastase has digested and removed glycogen. So who will become positive now? Only protein, right? So only protein will be positive. After diastase, this will become negative because it's removed and digested, right? So we came to a conclusion. This is an MCQ point, can come in a Viva. This I want you to remember forever. If any question says PAS positive, diastase sensitive, which means it is sensitive to diastase digestion, I want you to think of glycogen. This is one of the possibility. I want you to think of glycogen, right? Same time, a question says PAS positive and diastase resistant, which is resistant to digestion of diastase. This is protein. Okay, one is sensitive, one is resistant, right? Remember this forever. Okay, please remember, MCQs never come on facts. MCQs come only on concepts, right? Let's create an MCQ with this. Okay, 2-year-old kid, hepatosplenomegaly, failure to thrive, not growing properly. Liver biopsy showed pink color globules in HNE, which was PAS positive, diastase sensitive. What's your diagnosis? 2-year-old kid, liver biopsy shows PAS positive, diastase sensitive substance. What's your diagnosis? Can I easily extrapolate and saying von Geerk's disease? Possible? Definitely possible, right? That's how we create an MCQ, right? Let's change the question a little bit. Okay, same 2-year-old person, failure to thrive, and the patient died because of some cardiac disorder. Biopsy showed PAS positive, diastase sensitive substance, right? Cardiac disorder, biopsy showed PAS positive, diastase sensitive. What's your diagnosis? What's your diagnosis? Anyone? Von Geerk's disease might not present with cardiac problem. If you remember the table of glycogen storage disorder, what you read in the first year, which will involve cardiac tissue. Glycogen is very easy, which will involve cardiac tissue. Which glycogen storage disorder will involve cardiac tissue? Have you heard about disease called as Pompe's disease? Pompe? Shake. I said it's a glycogen storage disorder involving the cardiac tissue, right? Pompe's disease will involve cardiac tissue, right? Perfect. Now, can you create a question for McArdle syndrome, Hertz disease? You can. Muscle phosphorylase? I have a different answer. Liver? I have a different answer. Heart? I have a different answer. Concept remains the same. Don't expect, I read in von Geerk's disease, question should come only in von Geerk's disease. It won't come like that, right? I'm not making, see, my goal is not to make you clear second MBBS. That's a useless goal. Goal is to become an amazing doctor. So I remember one thing, I apply the same thing to whatever it is, I come to a beautiful diagnosis, right? Same way, this is protein. Doesn't mean alpha-1 antitrypsin deficiency. Anything which is protein will be PAS positive, diastase resistant. I can use for anything. I can even say that I had a plasma cell with loss of PAS positive, diastase sensitive substance, which is Russell body, right? That's how it is, right? Any protein accumulation will have the same finding. PCT, I can say the same thing. I'll have the same finding, right? Thank you, Aish. Okay. Read well, become amazing. Okay. That's it, right? So these are a few examples of protein accumulation. I'll add one more example and then we'll wind it up. Okay. Perfect. Last but not the least example is there are possibilities in most of the cells, not just liver cell or hepatocyte, any cell, we have something called cytoskeletal proteins. The cytoskeletal proteins which are there in every cell will also be pink in color. So if the cytoskeletal protein is damaged, I have an altered pink color. Just remember this, we will use them whenever it's required in systemic pathology. Fine? Okay, amazing, done. Okay, so we're done today with your fat accumulation and also your protein accumulation, right? Any doubts, do let me know, otherwise we'll call it a day. Tomorrow we won't be having RRS session. I think Monday we'll start it back again. Tomorrow is a holiday, Sunday, enjoy. Any doubts? If not, let's call it a day. Thank you guys. See you on Monday. Bye.